What's up, CardioNerds? This is Dan and Amit, and we can't thank you enough for tuning into CardioNerds. Your support as listeners since December of 2019 means the world to us.
We are honored to announce the birth of a new podcast, CardioNerds Cath Masters, designed to democratize interventional cardiology education. This is intended for an advanced audience with a strong technical foundation. At Cath Masters, we aim to deliver high-quality, evidence-based, and experience-driven procedural education across all segments of interventional cardiology. If this resonates with you, we invite you to check out Cath Masters on your favorite podcast app. As you have done with CardioNerds, please do rate and subscribe to the show to help others seeking interventional cardiology education also find Cath Masters.
The breadth and depth of CardioNerds education have been possible because of all our collaborators within the CardioNerds Academy, Healy Honor Roll and Fellowship programs, and several cardiovascular professional societies. We want to take a moment to thank them all for supporting our mission to democratize cardiovascular education. And of course, thank you for tuning in.
Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated cardio nerds everywhere are working hard to fight this global epidemic. These are their stories.
Welcome back, Cardio Nerds. I'm Apoorva Gangavelli, House Chief of House Einthoven, and today's episode is a special one. It's part of our CardioNerds Academy curriculum, where we pair deep dive podcast discussions with peer-reviewed scholarship. Speaking of which, a companion review article on tricuspid regurgitation will be published in US Cardiology Review, so be sure to check that out once it's live. Today we're tackling one of the most intellectually rich topics in cardiology, tricuspid regurgitation. Leading today's discussion is Dr. Cory Sejo. Cory is a third-year general cardiology fellow at the University of Chicago and a CardioNerds fellow in House Einthoven. He's staying at Chicago for an additional year of advanced cardiac imaging training and a particular academic interest in non-invasive hemodynamics and med-ed. Cory, welcome.
Thank you for the introduction, Apoorva. So great to be with you all today. I want to introduce my colleague and friend, Dr. Joseph Kassab, the PGY3 internal medicine resident at UT Southwestern in Dallas, currently applying into cardiology. He is a CardioNerds fellow in House Einthoven with me and is passionate about structural and interventional cardiology, with most of his research focused on valvular heart disease. Joseph, how are you doing today?
I'm doing well, thank you, Cory, and thank you for the introduction. I'm excited for this episode. Today, we have the pleasure to be joined by our expert guest, Dr. Sunil Mankad, to guide us through tricuspid regurgitation. Dr. Mankad is a professor of medicine at Mayo Clinic College of Medicine in Rochester, Minnesota. He is a fellow of the American College of Cardiology and the American Society of Echocardiography, where he has also served as board of directors from 2013 to 2016. He has published hundreds of manuscripts and won various teaching awards. Dr. Mankad, thank you so much for joining us today.
It's my absolute pleasure to be here. It's an exciting topic.
I want to say I had the pleasure of going to a few of your talks, Dr. Mankad, at the American Society of Echocardiography conference just a couple of weeks ago now in Colorado. Also, I took echo boards yesterday, so I'm familiar with all the topics that you gave there, so I appreciate all the learning that I've already received from you, but I'm so excited you could join us today so we can continue learning from you. And with that, let's jump right in. So tricuspid regurgitation, I see that on almost every echo report. And since it's so common, probably not a big deal, right? Dr. Mankad, can you walk us through how you think about the importance of tricuspid regurgitation?
Thanks, Cory. Tricuspid regurgitation used to be called the forgotten valve, but it is that no more. As you said, it's very common. About 4% of individuals over the age of 75 have moderate or greater tricuspid regurgitation. So tricuspid regurgitation is common. Tricuspid regurgitation is bad. It's associated with increased mortality through all its different levels, mild, moderate, and severe, but especially moderate and greater tricuspid regurgitation is really associated with poor survival. And this is true regardless of left ventricular ejection fraction, regardless of the status of pulmonary hypertension, and regardless of the mechanism of tricuspid regurgitation. So it is very important, especially when it becomes moderate or greater. We need to track its progression and, as we'll go into, try to quantify it.
Oh, wow. I guess we should learn more about the tricuspid valve then. So when we read about interventions, we commonly see discussion about valve anatomy. Dr. Mankad, can you tell us what is special about the valvular anatomy of the tricuspid valve and what makes it different, let's say, from other valves like the mitral valve?
Sure. So the tricuspid valve is the largest valve. It's the most anterior valve. Classically, there's 3 leaflets, but often, maybe up to 30 to 40% of the time, there's 4 or more leaflets. Now that's a little bit of semantics because some of the leaflets are divided into different scallops, but nonetheless, its anatomy varies quite a bit. The annulus is much bigger than the mitral valve. It has a triangular shape, but as it gets more abnormal, that triangular shape is lost and it becomes more oval and more flat. Because the right ventricle is very preload dependent, it can change its dimensions easily, becoming larger or smaller, depending on the volume status. That annulus can also change its dimensions quite readily to volume challenges. In addition, unlike the mitral valve, the chordae often are inserting directly into the ventricle. There's no papillary muscle that you can clearly see. There are some papillary muscles in the right ventricle, but the chordae can insert directly onto the ventricular surface. And these chordae become very important when you decide about intervention on particular leaflets. So it's larger, the leaflets are thinner, it's more apt to change with volume status.
Thank you for that overview. This reminds me we have a patient we're seeing in the CardioNerds Valve Clinic for a while, and I was hoping to get your advice on how best to treat her. Miss Trish Regurg is a 71-year-old woman with a past medical history of AFib, long-standing hypertension, obesity, type 2 diabetes, OSA, a prior CABG many years ago, and ischemic cardiomyopathy with HFrEF, with a CRTD placement. She previously had severe ischemic MR, which was treated with a mitral clip, deemed too high risk at that time, and her MR has been reduced to mild. A TTE from 2 years ago shows a mildly dilated LV size with an EF of 33%. The RV was moderately dilated with a mildly reduced function by TAPSE and a fractional area change. Her mitral clip appeared normal, and she has mild residual MR with a low diastolic gradient across the mitral valve. The report notes moderate TR. Both atria were dilated, and the patient was an AFib at the time of the study. Could you talk to us about the possible etiology of her TR? How do we grade the TR severity in general for patients like her?
Wow, this patient has many possible causes of tricuspid regurgitation. When you look at tricuspid regurgitation, you want to find out first, is it primary, which is the minority of cases, maybe 10 to 15% of the time, or is it secondary, which is 80, 85% of the time, and then a new entity, cardiac implantable electrical device related. In other words, a device impinging on one of the leaflets. All 3 of the secondary types are probably present in this case. Now, when you have secondary tricuspid regurgitation, it's important, and this can be delineated by echocardiography, both 2D and 3D, whether it's a functional TR related to dilation of the atrium and dilation of the annulus, or there's a problem with the ventricle where the ventricle dilates, and that causes tenting or tethering of the leaflets, a different mechanism. In other words, atrial functional tricuspid regurgitation is simply a dilated annulus from a dilated right atrium, whereas ventricular functional tricuspid regurgitation is the ventricle is dilated, often because there's pulmonary hypertension and RV dysfunction, and the leaflets become somewhat tented and tethered. And then, of course, you throw in the cardiac implantable electrical device, and all of those are really a possibility in this case. The echo is very important to help identify the mechanism, because if it's just atrial functional tricuspid regurgitation, we'll treat it one way, and if it's ventricular functional, we may treat it an entirely different way. It's also very important that we make sure that the patient is optimized and euvolemic when we assess the tricuspid regurgitation, or we may need to reassess it after diuresis and treatment when the patient is optimized to get a best idea of the dysfunction. Regarding the quantification, and I think we'll get into this a little bit more, it's very important to quantify. There's different methods that are utilized. I don't think any one method is better than another. It's what your individual lab does best. There's this semi-quantification where we look at something called the vena contracta, or the width of the jet just proximal to where the valve is. You can do that either in a monoplane or biplane, or even a 3D method to assess that vena contracta, or the width of the jet. But then quantifying methods is probably the best way, and it can be done with a continuity equation where we calculate the stroke volume going out the right ventricle, with pulse Doppler and the RV outflow tract, and then calculating the stroke volume going out of the right ventricle, and then the stroke volume going into the ventricle across the tricuspid valve. And you can subtract that from what goes out, and then you know what's left is what has gone backwards. In other words, more stroke volume will be coming in than going out because part of it will be going backwards. The continuity method is good, but it's tough, and I don't think quite as reproducible by echo. 3D echo may make it better, but still not quite. And the technique we utilize at Mayo Clinic mostly is the PISA method, or proximal isovolemic surface area, where we quantify the regurgitation, making a lot of assumptions, assuming that it's a circular orifice, which we know it never really is, but nonetheless, it's a reproducible method. In other words, although it may not be accurate, it's precise and reproducible if you do it well. And that will calculate the regurgitant volume, and then we can calculate the regurgitant fraction from that. So it's important to learn to quantify. And once again, 3D is really critical to identify the mechanism of the regurgitation, but we do primarily 2D methods to quantify the regurgitation.
Wow, thank you so much for such a nice overview of the echo methods for grading TR. And it sounds like she maybe likely has functional TR, as you discussed, given her multiple potential reasons. It also seems like the tricuspid valve is very complex and difficult to assess. You talked a little bit about 3D echo. I was wondering when we need kind of more than just a transthoracic echo. When should we be reaching for more advanced modalities like transesophageal echo, cardiac CT, cardiac MRI even, to evaluate TR?
Yeah, and one thing about the 3D, and Cory, your lab is actually the revolutionaries in helping us, along with the group in Milan, Italy, of using 3D to visualize the leaflets of the tricuspid valve. And 3D transthoracic echo is actually superior than 3D transesophageal echo, unlike the mitral valve. And that's because the valve is so close to the sternum, it's an anterior structure. And then we can see an en face view, a bird's eye view of the leaflets, and we can see exactly where that device lead is, and whether it's in one of the commissures safely tucked in there and not interfering with the leaflet, or in the middle, maybe not interfering with the leaflet, or is it completely inhibiting leaflet motion? And that's where 3D echo can come in. Now, when do you need TEE? Well, if the images are no good, certainly you need to go to TEE next, and you'll get great views. If we're considering an intervention, transesophageal echo is crucial because we need to measure certain parameters, one in particular, the gap between two of the leaflets. And if it's a large gap, more than 7 or 8 millimeters, it makes a clip very unlikely to succeed. So before any intervention, whether it's tricuspid clip, whether it is a transcutaneous tricuspid valve replacement, transcatheter, you need to have a transesophageal echo. And it will confirm some of the findings on the TEE transthoracic echo, but enhance our ability to intervene and whether we can intervene. Now, when do we go to CT? Well, once again, when we're thinking of an intervention, the exact three-dimensional measurements of the annulus become crucial. And although we can get those measurements with 3D TEE, the gold standard is really CT and three-dimensional CT. So when we're sizing the annulus for a potential intervention, when we look at the leaflets a little bit closer for an intervention, we need CT. Now, generally, MRI is very good at quantifying right ventricular volumes and assessing right ventricular function. 3D echo is getting better and better and getting closer to MRI, but it's still not quite as good as cardiac MRI. So evaluating the RV volumes and function is when we would use cardiac MRI. I guess on occasion we can use it to quantify the tricuspid regurgitation, but generally we don't use it too often for that.
That's great to keep in mind as we move forward. Thank you so much, Dr. Mankad. So going back to our patient, she's returning to the clinic because she's not doing too well. She has been having months of worsening symptoms of volume overload, fatigue, and early satiety, and her diuretics just don't seem to be working as well. When we saw her in clinic, she was in atrial fibrillation and appeared volume overloaded with a clinically elevated JVP, bilateral lower extremity edema. So we got a repeat TTE showing stable EF in the low 30s with moderate RV dilation and moderately reduced RV function by TAPSE and visual assessment. The mitral clip appears stable with only mild residual MR. but her TR had progressed to massive 4+ with systolic reversal in the hepatic veins and a vena contracta width of 15 millimeters. The CRTD leads did not appear to be interacting with the tricuspid leaflets. So, Dr. Mankad, the echo report says that there is massive valvular disease. Should we go ahead and send our patient for a surgical tricuspid intervention? Can you tell us a little more about how to manage these patients with TR?
Yeah, absolutely. No, we shouldn't jump right to an intervention, whether that's surgical or interventional in the cath lab, because sometimes as these patients develop worsening TR, that early society, there's gut edema, and they don't absorb their oral diuretics very well. So we really need to give her aggressive, sometimes and often inpatient treatment of her right heart failure. And that's usually IV diuretics and often hitting multiple areas of the glomerulus and potentially even some inotropic support of the right ventricle if it's failing. But we need to get her completely optimized with guideline-directed medical therapy, including sometimes what we would call prehab, or really getting them optimized with an inpatient hospital stay, and then reevaluating the tricuspid regurgitation. And if it continues to look the same, then potentially either surgery or an intervention. And there are ways we can help decide what to do there, and we'll talk about that. But no, do not jump right into an intervention. Try and give her IV medications and optimize her guideline-directed medical therapy first, and then reevaluate when you feel she's euvolemic. In other words, you can guide that a little bit by the size of the IVC or your clinical exam.
Thank you so much. That was very helpful. So as a small follow-up question, let's say the patient has become euvolemic. Is there a place in the evaluation to get a right heart cath?
Absolutely. So it's crucial to know what the pulmonary artery pressure is. And although echocardiogram is very good, the problem relies once you get severe tricuspid regurgitation, that it's very difficult to accurately predict what the right atrial pressure is. There's often equalization between the right atrium and right ventricle. So the right heart cath, to confirm that this is indeed a low cardiac output state, heart failure, but also to confirm what the pulmonary artery pressure is. Because if the pulmonary artery pressure is very high, that's a pretty bad, ominous situation for any tricuspid intervention. But certainly it would probably exclude a transcatheter valve implantation if there's severe pulmonary hypertension. A right heart cath is always a good thing to judge. And if we're doing that rehab, we often admit the patient, do a right heart cath, leave the catheter in, bring her to the CCU, and get them completely optimized with getting that right atrial pressure as low as we can, optimizing her hemodynamics. So I would have a very low threshold to go for a right heart cath, especially if we're uncertain of the pulmonary artery pressure and uncertain of the pulmonary vascular resistance, which needs to be calculated as well.
Going back to our patient, she was admitted for IV diuresis. We did a cardioversion at the end of the hospital stay. A right heart cath was done with mild to moderately increased pulmonary artery pressures once she became euvolemic. Unfortunately, sinus was short-lived, and she was discharged with a close follow-up. Over the subsequent months, she received an AFib ablation, but continued to have admissions for decompensated right heart failure, and it was difficult to control her volumes or symptoms as an outpatient. It seems like medical management alone is likely not going to be sufficient. Given her age, her comorbidity, her prior sternotomy, we were mindful that isolated surgical tricuspid repair or replacement in this population tends to carry a high operative risk. How should we be thinking about cardiac surgery for isolated tricuspid valve intervention versus newer transcatheter options like tricuspid transcatheter edge-to-edge repair and tricuspid replacement with EVOQUE?
Yeah, and I want to make sure people understood that you did try to get rhythm control, because that can be crucial. Rhythm control can really shrink that annulus and make the tricuspid regurgitation bad. And it's always the chicken or the egg type situation. You say, oh, it's so much TR, we'll never be able to get them in sinus rhythm. But it's still worth a try because it would avoid further interventions. Now that this patient is not doing so well, we do have to think about our intervention. And two different groups, the Europeans have created a score called the TRI-score. It's complicated, but there's a calculator. You put in the variables, what the creatinine is, what the patient's pulmonary artery pressure is, what the certain RV function values are, and other comorbidities. Or another score that was developed at Mayo Clinic by some of my colleagues called the TRIO score, which is a little simpler. But What these scores then can predict is the operative mortality. So if you have a low tri-score or a low trio score, your operative mortality is only a couple percent. However, our patient, the one that you described, is likely not to have that good a score. It's going to be at least moderate or elevated. And then the operative mortality goes up considerably, maybe 5%, maybe even 10% if their score is very high. So we have these score calculators that can help us decide. And if their score calculator is high, then surgery is really not a good option. Now, if it's in the middle, I think that's where you have to discuss things, and probably in your patient that already has RV dysfunction, it's going to be a moderate or higher score. I would think tricuspid intervention. Now, that would either be a TriClip or a clip of some type or a transcatheter valve replacement, currently either part of a clinical trial or part of the approved one, which is the Evoke valve. So calculate the score with either the tri-score or the trio score, then get an idea of what their operative mortality is, and then make a decision about transcatheter edge-to-edge repair versus Evoke. Now, when you think about if they're not a surgical candidate, whether to go for the TriClip, which is the approved one currently, or the Evoke valve, a transcatheter valve replacement, many things are important. Atrial functional TR, generally we lean towards TEER or TriClip, whereas if it's ventricular functional or tethered leaflets, or if there's a pacemaker lead, or if the coaptation gap is wide, more than 8 millimeters, then we would go with more likely an Evoke valve. It's also important to integrate the right ventricular function, because when we put in a clip, there's still usually mild to moderate tricuspid regurgitation, and the drop in RV function isn't as great as when you completely eliminate the tricuspid regurgitation, as usually occurs when you put in a transcatheter valve. So a ventricle that's on the verge of failing, if you put in an Evoke valve, it will completely fail. And these are things that you have to look at and integrate into the picture in this case. But our patient, as you described, it's a complex decision. We really need to involve multidisciplinary team approach, cardiac surgeon, the interventional structural cardiologist, the valve doctors to make sure they understand the mechanism by echo. We'll calculate the risk score by either the European model or the Mayo Clinic model. Then we kind of decide and discuss it with the patient. Patient preference is very important too.
Those are such great points. You also mentioned earlier the unique nature of the RV and the tricuspid valve and the interplay between those. On a previous podcast that we've done, we discussed the benefit of assessing RV function, specifically RV to PA coupling, which for the listeners is essentially the RV's ability to match its contractile function to the load of the pulmonary circuit, its afterload. How do we think about the state of the RV? And I know you touched on this a little bit, but how do we think about the state of the RV prior to intervention, and specifically maybe RV to PA coupling? And does that specific evaluation play into choosing between those two interventions?
Assessment RV function definitely does. I think the coupling, where you couple any RV parameter with the PA pressure, a variety of different parameters, that carries prognostic information as to how they do after any intervention. As of yet, it hasn't made the guidelines, so I would say reserve that for research at this point, and I wouldn't use it to make a clinical decision. But assessing the RV function is very important. We now have the ability to do 3D right ventricular ejection fraction. Then if we calculate the tricuspid regurgitation volume, we can get something called the effective RV ejection fraction, because we know what goes backwards. And it can be done in minutes in your lab. The University of Chicago are pioneers at this, of course, but now it's become mainstream to do it. Labs are adopting a three-dimensional approach. I think that fractional area change is limited, has a lot of flaws, and 3D volumetric approach will replace it. In our lab, we do all the parameters that you mentioned, the TAPSE and the tissue Doppler velocity of the tricuspid annular plane velocity. But I think the best way to assess RV function is free wall longitudinal strain. You have to align the right heart appropriately, and using speckle tracking techniques, you can calculate strain or the deformation of the wall. And there are cutoffs, and when you get below 13 or 14%, you have severe RV dysfunction. Normal strain is around 25%. So this is a way to quantify it and see the changes that occur. And especially if you're waiting and looking at a patient with progressive tricuspid regurgitation who may not have very much in the way of symptoms as of yet, knowing when that strain starts to get abnormal that could be a clue that, boy, we better do something quicker. So strain, 3D, the best way to assess the RV by echo, more so than fractional area change, but all those parameters are important. Coupling it to the PA pressure, intriguing, and probably has a lot of relevance and will in the future, but currently I don't believe it's in any of the guidelines. So I would reserve it for research at this point.
Those are really great points. Thank you so much, Dr. Mankad. Ultimately, Mrs. Regurg was presented at a multidisciplinary valve conference, and her surgical risk, as you said, was felt to be too high for an operation. Given her acceptable leaflet coaptation gap and leaflet length, along with the concern about her poor RV function, she did undergo a tricuspid tear with reduction in her TR to mild moderate. As an update, she came to the clinic a few months later with greatly improved symptoms and increased energy levels, and we were even able to decrease her diuretics. Dr. Mankad, I mean, this is an excellent case. I think that we started from the presentation to the management. Can we ask you a little more, for example, about TR related to CIED, and what are the management considerations in this population?
Well, listen, it's still an ongoing research to really understand how to intervene. So the key points here are that an en-face view of the valve, and that would be with 3D transthoracic echo, usually from the ventricular perspective, but either the atrial or the ventricular perspective. And your lab should get very good at doing transthoracic 3D of the tricuspid valve. And then you'll know for sure whether there is lead impingement or not. If you have to do it by TE, the transgastric view gives you a nice short axis where you can see all three leaflets in the majority of TEs that you'll be able to do. And that's another way to tell if the lead is interfering. As to what to do about it, well, if I knew, the King of Sweden would call with my Nobel Prize. Nobody knows what to do with it. You can try to manipulate it, and we have had successful cases and published where very early on, after placement of a device, when there was more tricuspid regurgitation developing, we repositioned the device lead and the tricuspid regurgitation got better. But to be honest, we often don't discover this early on, and we discover it years after the device was implanted. And at this point, there's a lot of adhesions, fibrosis, and you'd be surprised. Sometimes our EP colleagues, they can't really see the leaflet, so you don't know where they put it. Sometimes it skewers a leaflet. So removing it and repositioning it has not been proven to benefit as of yet. It is an ongoing area of research, and we're still learning about it. But the important thing is, once you identify the lead as the cause, you're almost obligated to go for a transcatheter valve implantation rather than a clip. The clip, in all the studies, it was an exclusion criteria to have it be pacemaker-related TR. It could be an incidental finding, and then you could still go with the clip. But if they felt it was pacemaker-related, we didn't include any of those patients in our studies. I really don't know that I can say what to do with it. My own opinion is that if you discover it very early on, you can try repositioning it. But if it's later on, I think it's very unlikely to be of benefit to reposition it. The one exception might be when you have very much of a looped lead that's kind of really floppy and going across the tricuspid valve. Sometimes pulling it back can be done pretty safely, and it may improve the TR. It never hurts to try that, but be careful. If you've done lead extractions in patients that have had leads in for a while, you know that many things can get torn if you try to remove that lead later on. So it's unproven that it really improves the outcome. Echo, though, is very good. 3D transthoracic, transgastric view by TE to know if the lead is the cause of the problem. But really, to be honest, we must give applause to the University of Chicago for really teaching us about the use of 3D echo in that technique. But we should all learn 3D transthoracic echo of the tricuspid valve because it's really the best way, and in fact, the only way to be sure that the lead is impinging on the leaflet.
Thank you again for such great points and compliments to my university. I always appreciate that. I also wanted to kind of get your opinion on where the field is going, either continuing research or kind of how things have progressed even at Mayo over the last couple of years in terms of choosing between these two transcatheter options, any additional ones that are going to be coming through, any new studies that are going to be published, and how do you feel the field's going to be dominated?
Yeah, so, I mean, there are a lot of new valves coming out in different locations, valves that will occlude the IVC and the SVC. and not even be in the heart, but help prevent the regurgitant volume from going back to the liver and causing damage. There are a couple of key questions to ask when you're deciding what to do. First of all, you need to ask, is the patient able to tolerate anticoagulation? If the answer is no, it's not safe, we cannot give an evoked valve because the evoked valve recommendations are for anticoagulation really lifelong because of leaflet thrombosis risk. Then you need to ask, is the TR pacemaker related? Is the coaptation gap large, more than 8 millimeters? Is there leaflet tethering? If that's the case, then a clip is not likely to benefit, and we would go towards transcatheter tricuspid valve replacement, the Evoke being the one that's clinically approved, but many other valves are being tested. If you go to any meeting and there's interventional cardiologists presenting, this is our new valve. We did the first in human, 5 cases. We finished in 10 minutes, and there was no complications. But the truth is there are complications, but we'll see more and more valves being developed. Now, the other question to complete the key questions to ask, is there severe pulmonary hypertension, and is it irreversibly high peripulmonary vascular resistance? Because then you really don't want to eliminate that TR or that right ventricle will fail. So you really are obligated to go with a TEER device, clip, and allow some backflow to occur so that the right ventricle doesn't completely fail. And if the RV has severe dysfunction by whatever parameter, we like strain imaging and 3D imaging, but if there's severe RV dysfunction, probably no intervention will help. The key question to ask often, and this is why really intervention earlier is probably best, although we can't prove it yet. There are ongoing studies. We know that if you do isolated tricuspid valve surgery, when your risk score is low, there's a couple percent mortality, 2%, 3%. And at some centers of excellence, it may be close to 1%. And if you do, wait until they have ascites, wait until they have any kind of end organ dysfunction, then the mortality goes up to 10%. So we have to intervene earlier. Most of the tricuspid clip and valve replacement trials and in clinical practice right now is when they are pretty far along and too high a surgical risk, that's when we consider these devices. But I think it's going to continue to increase. Whether you're an invasive cardiologist, interventionalist, or a non-invasive cardiologist, we have to learn to do both. Interventionalists will need to manipulate catheters. They'll need to learn ICE. Intracardiac echo is really a very good way to guide many placements. In fact, we use ICE alone for the majority of our transcatheter valve replacements currently. If you're a non-invasive cardiologist, you have to become a master of 3D. As Cory, I think, is going to do an extra year, that's the only way you can get trained in an interventional echo and really become skilled at it. So these are the pathways. I would say it's still exciting. It's still fun. I still love coming to work every day. And although AI will change everything in what we do, I still think the field of interventional echo is still quite a many years away before AI will really be able to do the things we do in the cath lab. But they're trying to create robots, and someday they probably will, but currently not on the horizon. So your future is still bright if you want to go into that field.
Okay, let me see if I can sum this up. A few key points from our discussion today. 1, tricuspid regurgitation is common and associated with increased morbidity and mortality. There can be regurg due to primary leaflet issues for functional reasons, atrial or ventricular enlargement, and due to various interactions with device leads. The tricuspid valve apparatus is complex and involves many surrounding structures. TR is dynamic and changes with various loading conditions similar to the RV. Third, medical management with diuretics is the first line for treatment of clinically significant TR. Generally, severe left-sided lesions are addressed first, followed by maximum GDMT. And when this is not enough, invasive interventions can be considered. Fourth, when choosing an intervention strategy, it's best decided as a part of a multidisciplinary valve team. Transcatheter options include tricuspid valve clips and transcatheter replacement with the Evoke valve. Dr. Mankad, are there any additional points you want to emphasize to our listeners?
Nothing major. That was a great case and illustrates really superb management. I don't know what institution that occurred in, but really the patient was excellently managed. The only topic that we didn't really cover, and this is just a quick point, in patients undergoing left heart valve cardiac surgery, it's very important that we measure the tricuspid annulus just in a two-dimensional plane. And if it's more than 4 centimeters, and there's mild to moderate, or let's just say moderate TR, then the guidelines do recommend fixing the tricuspid valve at the time of the left heart operation. So keep in mind, even when it's not the focus of the operation, such as a mitral regurgitation is the operation undergoing, measuring that annulus is important. At least you can lead the surgeon to the door and show him the data, and it's up to the cardiac surgeon to decide whether they intervene or not. That's one point we didn't cover, but this case was excellent, and I think the entire team should be congratulated. Well done.
Thank you so much for saying that. We had such a wonderful time speaking with you today, and thank you for being here. Here at CardioNerds, we always like to ask our guests, what makes your heart flutter about tricuspid regurgitation or valvular disease in general?
Well, listen, the truth is I'm more of a mitral guy than a tricuspid, but I do think that the field of 3D echocardiography has really revolutionized valvular heart disease. When we're able to show pictures to our cardiac surgeons or our interventional cardiologists of exactly what the valve is doing by 3D echo, that kind of what makes my heart flutter. I love this quote. It's actually from James Dean. It says, "Dream every night as if you could live forever, but live every day as if it could be your last." And I do dream every night, and when I dream in 3D. Thanks.
Thank you, Dr. Mankad. And CardioNerds, thank you for joining us today. We hope you learned something about tricuspid regurgitation. Until next time.
Thank you so much for tuning in to this CardioNerds episode. The audio editing for this episode was performed by me, Emma Winakur. I'm an intern in the CardioNerds Academy and a graduate of Syracuse University. Check out the episode page for show notes and references. If you found this episode or the show informative, please consider subscribing to CardioNerds on your favorite podcast platform and leaving us a review. It really helps us spread the word and further our goal to democratize cardiovascular education. Finally, this podcast is not meant to be used for medical advice. The views expressed on our show and site do not reflect the opinions or policies of our employers. All CardioNerds content is planned, produced, and reviewed solely by CardioNerds. Stay tuned for more engaging conversations and explorations in our new and exciting upcoming episodes. And now, my friends, it's time to make like an S2 and split.